Barbara, were you able to get a hold of Wilma? You have to unmute. There you go.
I don't know if that iPhone wouldn't be hers. Do you know who's the iPhone?
I can.
Because I tried calling, it went right to
Last
voicemail.
I knew, Wilma had a Android phone, but she may have
Oh,
gotten an
you're
iPhone.
right. She doesn't have an iPhone. Nope. I tried calling. There's nothing I can do. When
Okay,
do you think we should get started? Let's get started.
yeah, yeah.
Okay, great.
Okay, well, for anybody who is new to any of our virtual committee meetings, you'll notice that you're muted right now, and you're going to stay muted through the duration of the meeting, except for whenever one of our co-chairs, Barbara, or if she's able to join us, Wilma joins, and if they call on you. So as we go through the agenda after our presentation, you can participate by going to the reactions on your device, the reactions menu on your device, and pressing the raise hand button there. Don't press the wave or the thumbs up; those will disappear. If you look for a prompt after we call your name for it to say confirm unmuting, so look for that once you've been called on. And if you're having problems, the chat is available for technical support. It is not to ask questions of our presenter today or any of our committee members or co-chairs. They will never see those chats. So if you're having problems with Zoom, you can chat me, you can chat Rose. We're here to support. But with that, I'll hand it over to Barbara and she can get the meeting underway.
Thank you. As I was saying to Rose, to Jesse before, I heard about this mental health initiative by the borough president at his State of the Borough meeting. And after that, at our community board meeting, and I was just so excited to hear about it. And that we're so pleased that Jessie Lang has come. She is a policy analyst at the borough president's office, and she's here to tell us in depth about the plan. And we'll have time for questions after, but thank you so much for coming.
Happy to be here. So y'all ready for me to get started with the
Sure,
presentation?
please do.
Okay, great.
Great.
Okay, so I'm just going to go ahead and share my screen. I didn't prepare a full slide deck or anything, but we have a really helpful one pager. Can you all see this now?
Yes. Mm-hmm.
Okay, great. Yeah, we have a helpful one pager that I thought it would be helpful to frame the conversation. We also have the full plan available on our website that really breaks each of these components down one by one. But I hope to break this down as well for you all tonight, and happy to answer any questions. But I'm just going to zoom in a little bit so that we can actually see what we are. Let me just make the participants a little smaller. Yeah, so really Barbara, as you mentioned, this was something that the borough president brought up at the State of the Borough. This was a plan that we as an office released last December, I think around mid-December maybe. There was a New York Times article that featured the release. So whatever the date of that New York Times article, that's the date that we released the plan. But really, essentially, you can kind of see it at the summary up top. But we have a mental health crisis happening in New York City right now. I think that is probably no surprise to many of you. And there are a lot of things happening that are causing this mental health crisis and really causing so many New Yorkers with serious mental illness to not have adequate treatment and support. But this is something that, decades of disinvestment have left us with a behavioral health system that really just doesn't have the resources, the funding, the capacity in myriad different ways to support the people who need it the most. This is a plan that really very specifically focuses on New Yorkers with serious mental illness, and in particular, homeless New Yorkers with untreated serious mental illness. So that's kind of what it's under the umbrella of needing to bolster and improve investment in our behavioral health system, as well as other components of the behavioral health system, such as housing that I'll go into. But really, this is something that we need to do, to it's like really a moral imperative as we see it, to be supporting folks who really are some of the most at-risk New Yorkers, and for like a number of different issues because of their mental illness. And this is something that we need to be acting on really now. And it's really, we say that if we don't act boldly and quickly, a human tragedy will continue to play out on our streets. This is something that's already happening. And so we really need to be acting on this now. So just to go through some of the components of the plan, we really started by thinking about the need for expanded inpatient care. This is something that, the vast majority of people who experience mental illness and even serious mental illness do not actually need inpatient stays, particularly extended inpatient stays. But for the people who do need inpatient care and also then to have ongoing care following an inpatient stay, there is really inadequate beds available to them. You may have heard that during the earlier days of the COVID pandemic, hundreds of inpatient psychiatric beds were closed down, and that was to make way for care for people who were hospitalized due to COVID. But we're out of that stage of the pandemic now, and these beds are not being returned online. There are different reasons for that. It requires a lot of funding to do so. But two promising programs that we highlight here are the Transition to Home program. This is a statewide program that the governor launched last year. There are beds all over the state, but in particular in New York City, there are beds at the Psychiatric Institute on Randall's Island. And in addition to the beds that are currently online, where they are seeing like really quite tremendous success with people who are hospitalized there, there are a couple of buildings at the Manhattan Psychiatric Institute that are not being used at all. These were buildings that were initially built in, I believe, the 70s, but the buildings have been vacant for quite a while now. And they need really serious renovation to be brought back online. But we do believe that with state investment that we would be able to renovate those buildings and also bring them up to modern inpatient psychiatric care standards, because the standards of care now in 2024 are really quite different than what inpatient psychiatric care looked like in the 1970s. And so some work will be needed, but this is really a program that people can have inpatient care for 3 months to start, with extensions later on if needed. And it's really like a lot of people are staying there longer voluntarily. And it's also a program that is, as it's called, Transition to Home program, it is giving people access to resources to then go into the housing that they need after they're discharged from this program. The 240 new health and hospital extended care units beds, those are at New York City health and hospital locations, such as Bellevue, Harlem Hospital, in Manhattan, but other hospitals, across the city. And these are beds that are available for more extended stays, also for inpatient care. And really both of these programs are designed to take people who are admitted to a psychiatric emergency room who are identified to have a need for maybe longer term than just like a 72-hour psychiatric hold. But right now, what is happening is that a lot of those people, after their 48-hour, possibly 72-hour psychiatric hold, they are right now being discharged often back onto the streets, not having their long-term care needs met. And even if they want a long-term inpatient stay, oftentimes the beds are simply not available. So we think that the 600 in the transition to home program and the 240 in the health and hospitals extended care program is really a way to start to meet the need and make really significant investments in the inpatient realm. In the staffing shortages in behavioral health, this is an area that we heard from basically every type of service provider that we worked with when we were developing this plan. We talked to people who work in, I'll just make it a little bigger. We talked to people who work in supportive housing. We talked to people who work directly in clinics, to people who are on IMT teams, which are like mobile teams that I'll go into a little bit later. That's also a part of our plan, but really in every single pieces of where people are providing behavioral health services, from like social workers to psychiatrists to psychologists. There are staffing shortages, and even not even just like social workers, but even like front desk people and like receptionists and all of these different, people who touch this human service need. There are staffing shortages in every single one. There's a few different reasons for that. But a huge one is that a lot of people who are going to social work school or psychology school to be a clinical psychologist have tremendous student debt when they graduate, and the pay that is offered at health and hospital facilities, both including inpatient and outpatient facilities, is just not sufficient for people to pay off their student loan debt. So that's why we propose an expanded student loan forgiveness program to incentivize behavioral health workers who are newly graduating to work in the health and hospitals facilities. We also proposed creating a CUNY rotation for social work and psychology students at what are called psychosocial clubhouses. These are psychosocial clubhouses are spaces where people can go, whether it's people who are currently experiencing homelessness or formerly homeless people, to their spaces where people can start to redevelop their like different social skills and different like get connected with employment resources, things like that, and just really have a peer support network. I was able to, late last year, I toured one of the largest, or I think the largest clubhouse in New York City. It's run by Fountain House, and they have a few different facilities across the city. But really, like, seeing the impact that these spaces have on people's ability to connect with their healthcare needs, connect with employment resources, as well as just kind of have a peer support network to run things by, start to develop different like hobbies and skills, and just really have that invaluable social network. But what we learned is that when people are in social work school, they often don't learn about clubhouses at all. So this is like really an invaluable part of our behavioral health system in New York City, but so many people don't know about them. And so social workers and new psychology graduates just don't know about clubhouses, and like don't even know that this is a place where they could work. So we proposed there are different clinical rotations when you're in either social work or clinical psychology school. And we propose that these CUNY schools develop a clinical rotation for their students to have the option to actually be exposed to this form of care. The third thing is keeping up with the cost of living for behavioral health service providers. Both the mayor and the governor have proposed modest increases for behavioral health service providers kind of across the board. We would like to see even more investment to help attract people to this field of work, but also making sure that state raises as well as city raises are equal, because so that different behavioral health providers are kind of starting to see the same cost of living increase, and just have even more investment to ensure that these providers can be retained in their jobs and continue to keep up with their cost of living. So that's the staffing bit. The housing is really a big part of this as well. And we talk to a lot of different supportive housing providers, as well as the Supported Housing Network of New York, SHINY. And what we, as well as people who are impacted and who need supportive housing themselves. And we think that housing is a really core part of people's ability to be successful in being treated for serious mental illness. The difference between having a stable and permanent housing and being in the shelter system or experiencing street homelessness, it really changes people's lives to be connected with housing and makes them so much more successful in being able to treat their mental illness. And a huge part of that is being able to connect to supportive housing. So what supportive housing means is, if you aren't too familiar with it, is very broadly, it's housing that provides dedicated case management as well as other social supports that is like embedded in the housing itself. There are different levels of supportive housing depending on what the need is that people have and like kind of where they are in their care journey and being stabilized with serious mental illness. And I'll get into that in just a moment. But really, what we found is that of all of the different types of supportive housing, we need much more of it. There is really simply not enough supportive housing to meet the need of people who would be placed in it. Supportive housing is reserved for formerly homeless individuals. And there are extremely long waiting lists to get in. It can take a really long time for people to, even if they qualify, to get into supportive housing. And in the meantime, they're in the shelter system or on the streets, unable to get the care that they need because of what goes along with all of that. So the first two parts of this are really about increasing the supply of supportive housing. The getting major supportive housing projects across the finish line. A couple of the projects that we talked about there. I don't actually think that any of these projects are in Community Board 8. I don't know if you know of any like proposals for supportive housing.
We have
What's that?
We have a woman in need on 90, I think it's 91st Street. Christine.
Okay.
It's very successful.
Okay. Yeah, so I'm sure you have supportive housing in the district. Some of the projects that we're looking forward to are the Lirio in Hell's Kitchen is a project that will be reserved for formerly homeless people living with HIV and AIDS. Timbale Terrace in Central or East Harlem. I'm not really sure where it falls on the boundary there, but that's in Community Board 11. And was recently passed by City Council. These are the types of projects that we need to not only pass, which we have passed those two, and I think the borough president will continue to support additional supportive housing proposals in Manhattan, but also closing the financing on them in a timely manner. The Lirio was approved by City Council almost 2 years ago, and they just closed on their financing with HPD a week ago, and now can finally start building this really critically needed housing. So we need to make sure that this is happening quickly so that people can move in and aren't, getting this promise that is not being met. The passing zoning text amendment that's related to City of Yes for housing opportunity. I'm sure you have all heard that there are a lot of different components to that, but one that we're keeping a close eye on is the universal affordability preference, which would give a 20% bonus on top of a 20% FAR bonus on top of what is already allowed as of right, as long as that additional 20% is all 100% affordable housing. We think that that is a great opportunity for that to not only be permanently affordable housing, but also be supportive housing where possible, and to really start to increase the supply there as well. The next three are really about getting New Yorkers who need supportive housing placed quickly and efficiently and in the right type. All of the supportive housing referrals in New York City go through a centralized system. It's called CAPS. It's administered by DSS, Department of Social Services. And as I mentioned earlier, there are two different types of supportive housing. There is what's called licensed beds, or level 2, and that's for people who really need like 24-hour supports, on site psychiatric providers who can prescribe medications, and things like that. But that's not actually a permanent supportive housing. The kind that we hear about most commonly is what's called community care, or like you might just hear about it as supportive housing. That's the one that's most well known. That is permanent supportive housing. It has a lower level of service. That's one where you get case managers to help direct your care and get you to the care you need, but you won't have like licensed psychiatrists on site to prescribe medication, for example. So depending on where somebody is in their treatment for serious mental illness, they really might need one type of supportive housing over the other. And we think it's really important that that DSS ensure that when they are referring people to social housing through CAPS, that they are referring people and placing people in the type of housing that best suits their needs. We've heard from supportive housing providers that that's not always happening right now, and sometimes people are going into the lower level of supportive housing when they really would be more successful in the higher level of care. So we're working with DSS to identify ways and that we can fix that. Ensuring that the highest need New Yorkers are support prioritized really means that I'll talk about these intensive mobile treatment teams in a little bit, but there are a number of New Yorkers who are already connected with care providers, these like mobile care providers, and we want to identify a way to ensure that people who are already connected with care, and this is because they have very, very high need and are experiencing street homelessness, that those folks are prioritized for supportive housing that they need so desperately. The Family Care Housing Opportunity is a state-run program. It's often described essentially as it's similar to what you might think of as like foster care. It's actually New Yorkers who open up their own home or an additional room that they have to people with mental illness and who need housing. And sometimes people will open up 2 or even 3 bedrooms of their home. So this is something that we really want to expand. We really want to see the state expand information about so that more people who are interested in hosting both individuals and families who would benefit from this type of housing. And what we've heard from the state, as well as people who have opened up their homes in this way, is that oftentimes the individuals that they're welcoming into their home will sometimes stay for years at a time, and that they really do become a member of the household. And it's a completely voluntary program. Nobody who opts into it is required to do it. And from what I understand, you can kind of come in and out of being a provider of housing for this program. But a lot of people, both on the side of people who are opening up their homes to these folks, as well as the people who are coming into these homes, have been very, very successful in these housing situations. It's a unique model of care, but it has been it's been innovative and really successful, even though it's been at a small scale. So the next part about investing in and expanding behavioral health treatment, I've mentioned intensive mobile treatment teams a couple of times. These are teams of workers who include social workers. It includes a psychiatric nurse practitioner. There's a medical director supervising. There's different caseworkers on the team. It's a team of 5 to 6 people who are really going around New York City, and they have a client list, and you're not required to be homeless to be a client of IMT teams, but the vast majority of people who are clients of these teams are homeless. And really, this is a team who will come to you, who will evaluate your needs, prescribe the medications that you need. And they are really doing heroes work. Cases is one of the biggest providers of the IMT teams in New York City. Me and the borough president actually visited the Cases headquarters, and we got to meet with one of the IMT teams a couple of months ago and hear about what the challenges are that they're facing, what could make them more successful. And really what we've been hearing over and over again is that we need more of these teams. We need more staff to be doing this work. This is an incredibly valuable service, but that right now, it's very small. We want to double the number of teams so that we can double the impact. Right now, it's about 750 people who can be served by these teams, but the waiting list is thousands of people long. So even by expanding the capacity to supporting 1,500 New Yorkers, that is already starting to bring people off the waiting list and bringing care to people where they are, wherever that might be. We also think that we need to expand the certified community behavioral health clinic model. These are outpatient clinics that people are getting a lot of their behavioral health needs met at, but there simply are not enough of them, and these are state-funded programs that we would also like to see expanded. Finally, before I open it up to questions, we also want to improve access to substance use disorder treatment. Not everybody who has serious mental illness or is homeless, as I'm sure you know, also has co-occurring substance use disorder, but many, many people do. And many of the overdoses and unfortunately overdose deaths that are happening in New York City right now in the opioid epidemic it's really hitting homeless New Yorkers with serious mental illness. I think they are among the hardest hit New Yorkers. of this. So one simple thing that we can do is we can give EMS workers the ability to provide what's called buprenorphine. This is a medication that is people use long term to treat substance use disorder, or when they are in recovery from opiate use disorder. It's a medication that binds to the same opiate receptors to help reduce the effects of withdrawal as well as reduce cravings for opiates. And there are a number of communities across the country, and I'm sure internationally as well, who are starting to allow EMTs directly to give people a first dose of this medication. It's this is mostly provided for people when EMS workers are responding to a person who's having an overdose. They will administer naloxone, which immediately reverses the overdose. But before they leave, they will also offer the patient buprenorphine, and then take the next step and also connect them to care where they can start to get the long-term prescription. So the EMS workers would only be giving patients kind of their first dose, so that after an overdose is reversed, they aren't then, immediately sent into withdrawal without any support at all. But really giving them a bridge for the next 24 to 36 hours to actually get care without having those withdrawal symptoms be hitting immediately. This is an incredibly safe medication. We talked to a lot of people about this, and it seems like it's working really, really well to prevent relapse and keep people really improve the rate of medication-assisted substance use disorder treatment. So this is something that we're hopeful could also be replicated in New York. So with that, that is an overview of the plan, but I am happy to take questions, and we can go into anything in more detail if you would like.
I just have one comment. I read this and I had so many, you explained it so well and
Oh, thank you.
made me understand it. I thank you very much.
I'm glad to hear
Bill
it.
had said if you use your reactions to raise your hand. And is Wilma unmuted?
Yeah, she's
Yes,
here.
I am. I'm here.
Great. Hi, Wilma.
Hi.
Are there any hands raised at this
Not
point?
yet. So just remind everybody, if you have a question, you want to make a comment, look for the reactions icon on your device, and you'll find a button underneath that that says raise hand. So just press that and your virtual hand will go up and we can call on you.
Great.
So I see Ellen Pallavi has raised her hand.
Great. Hi, Ellen.
Go ahead and unmute Ellen.
Hi. Well, this was great. I'm so pleased to hear all the good ideas, and I think asking all the mental health professionals really you came up with good plans. I'm curious, as you know, the idea of housing first is very important for homeless people, and the way it works right now is you have to be virtually street homeless in order to get housing. Will there be a way for couch surfers, people that really have not had housing for a long time, but have been staying with friends, family, mooching off of people basically because they have no other place to go, and going from place to place? Will they have a way of getting emergency housing, or will they have to
Yeah,
go
so
our system first?
yeah, so right now, just to kind of elaborate on a couple of the things that I think you're touching on, you are right that for the vast majority of homeless New Yorkers to get connected with housing that is reserved for formerly homeless New Yorkers, that they do have to be what is called, they have to be identified as somebody who is chronically homeless. What that means is that over a period of 90 days, there's a whole definition of what the federal government means by somebody being chronically homeless, but they need to have stayed in the shelter system, experienced street homelessness. And you're right that this is leaving a lot of people who have these informal housing arrangements, but really do not have secure permanent housing. It's kind of leaving them, it's, you know, it's neglecting those folks. Some other groups that also don't qualify for permanent housing are people who are being released from jails or correctional facilities or incarceration, as well as people who are in domestic violence shelters and other forms of transitional housing. So again, these are like not forms of permanent housing, but right now for city subsidized supportive housing, all of those people that I've mentioned, including the people that you mentioned who might be staying on a friend's couch or couch surfing, whatever, they are not considered for this form of housing. There are different types of state-funded supportive housing that have a little bit more of lax definitions for who qualifies. I would have to double check the definitions, but the people that you are referring to might qualify for some of those types, but that the city's funded supportive housing is really the main, that's like the majority of supportive housing in New York City. We are trying to think about different ways that the city can think about expanding the definition of what it might mean, of what it means to be chronically homeless or homeless that qualifies for supportive housing. I think that one of the problems that we've encountered when talking with both supportive housing providers and DSS is that because there is such an overwhelming need for people who really are experiencing street homelessness, I think that they're a little bit, right now they are kind of in like triage mode of saying like, how do we identify the people who are really like most in need of this housing, like do not have a bed at all to sleep on. But I am hopeful that if we can continue to expand the supply of supportive housing across New York City, that we can kind of get out of that triage mode and start to get into thinking about other groups of people who would really tremendously benefit from this model of housing and really who do need it, rather than just trying to identify the people that are like absolutely in crisis right now. So hopefully that helps answer your question, but happy to take a follow-up if you'd have one.
I mean, it's frustrating, I know, because once you open that floodgate, you get all sorts of people coming in saying, I need housing. I've been staying on somebody's couch. So I understand that. What we really need is a lot of housing, a lot of affordable housing. It's frustrating that there's a lot of senior housing, but the waiting list, because there are so many seniors now, the waiting list is so many years. And many people living just on Social Security don't qualify for much of the housing because you have to have a higher income than some people have. So then, they might have missed the Section 8 housing deadline, and, because these things open for a window, a month, and then they're closed again. So if you don't, if you weren't on your mark and, you're actually homeless and you can't figure out, how to check for these things fast enough, it's open and closed. You miss the the whatever, I mean, everything keeps, things open and close all the time, and then they're closed again. And then you got to wait another 12 years before that list opens. And that lottery opens. So I don't know what the answer is, because being homeless drives people crazy. Having to figure out which couch you're going to live in, how to manipulate your friends so you could get them to, okay, you can stay here now. And then finally somebody gets fed up and doesn't let them stay anymore. And then they go on to the next friend. So they are always trying to figure out, you can't have a normal life when you don't have a home. And
Yeah.
so I don't know what the city can do to actually create enough affordable housing, but it is driving people insane. And
Yeah.
and then the other problem is that a lot of, you can't get into a homeless shelter with a pet. So if you don't want to give up your pet, what do you end up on the street. And if you start drinking or taking drugs because you're cold, or you've been driven insane, um, then you have to go into a program, and you have to give up your pet to go into a program. So what do you do about that? So you might actually consider having some shelters that accept pets.
Mhm. Yeah, we are, yeah, and I think, we will, we absolutely totally 100% get that this plan that we have come up with is not the fix, like it's not gonna fix every single issue that is affecting both homeless New Yorkers as well as New Yorkers with serious mental illness. And, you have mentioned that there is like a lot of overlap there. So we have a lot of work to do, even if we accomplished every single thing on, every single policy on this list. I think that would be like amazing. We accomplished a lot, but now we have a whole other list of things that we need to do. And I think that you're starting to touch on that. Um and this is we kind of see this plan as being what is like absolutely needed for people who are the most vulnerable and really the most in need of mental health treatment, who are not getting it oftentimes at all right now.
So I have one last question. How are you vetting the people um, that you have this housing share program? So how are you vetting the people and what happens, what happens if a match doesn't work out? What do you do then? Do you move into
Um,
some home or what?
Yeah, so the state is the one that administers that program. We actually didn't really hear of many cases where it wasn't working out, and I think that part of the reason why is because they do a really thorough job of vetting people and to make sure that the match um is going to work out. And there's like a lot of interviews on both sides of the, both people are interviewed by the state, and they meet with each other, and it's really like a very long, it's a very thorough process to be placed in that program. um there are safeguards if it doesn't work out. You're not uh the person who is opening up their home is not like stuck with a person permanently if it doesn't work out, and vice versa. If the person who is going into somebody's home to live there, if they're, if it's not working out for them for whatever reason, it's really like a voluntary program, and people aren't like, I think that there are certain commitments that people are expected to make, but you're not like signing all of your rights away when you open your home to somebody there. They do have safeguards, and there are a lot of check-ins with the state that to make sure that people are being successful. As I said, I don't think we heard of any cases where anything like really seriously didn't work out. I think that any of the cases where it didn't work out, people were able to kind of like voluntarily part ways with one another. But as I said, they have a number of safeguards in place to make sure that both the people opening up their homes as well as those who are going into these homes to reside there are able to be successful, and if not, that they're able to address that.
Okay.
Thank you, Ellen. Is anybody else raising a hand? If not, I have several questions. Can I go then?
Yeah,
Wilma, do you have
nobody else.
questions?
Yeah.
I see Wilma's phone. Okay, first, I just want to make a statement. Your comment at the beginning was this is a moral imperative, and I agree with it. It even goes beyond that. I mean, for those of us that want to have a nice life, that we have our own apartment, we spend, money on rent or whatever. It is so disturbing to have people that to address it is good for everybody. So you don't have to, I mean, even for people that where the morality part of it is not primary, this is just such an important program, and I'm so pleased that you addressed it. But I do have a couple of questions.
Sure.
First of all, generally, everything is voluntary, am I right? So somebody on the street does not have to go into the hospitals on Randall's Island or any other housing or anything. Am I right about that? Everything
So
has voluntary?
so I think you're referring to a couple of different pieces. The housing piece, yes, everything is 100% voluntary there. People actually, with supportive housing, people usually get like up to 3 referrals to different supportive housing providers so that they can tour them and figure out which one is the best match for them, both based on location and services provided and all of that. And sometimes, DSS really does the best that they can to make sure that people are being matched to the best type. With the inpatient care, there's a little bit more of a gray area there. We in this plan did not we did not get into involuntary removals from the street. We are thinking more about what is happening when somebody is admitted to a psychiatric emergency room, and then what is happening there. So there are different and I will say upfront that that process is not always 100% voluntary for a person, but there are kind of like different thresholds that need to be met to in order to have somebody have an involuntary psychiatric hospital stay. So when somebody is identified as being in the hospital, in the psychiatric emergency room, is identified as being either a threat to themselves or others, and they have to have like multiple physicians need to sign off on it, then that allows the emergency room to hold a person for 48 to 72 hours. After that time, they can, there are certain thresholds that can be met for a person to have a more extended stay involuntarily, in like an inpatient stay, and that might be on the Randall's Island transition to home. It might be in the health and hospitals inpatient extended care program, but that gets much more into, I said that this is a gray area, it gets much more into like a conversation between a provider and the patient. And while there are certain legal levers that providers can use to have somebody have an involuntary psychiatric stay, oftentimes it's really like it's not really like it's not a black and white, like I am committing you to stay involuntarily. It's much more of a dialogue from what we heard from providers between the patient and the provider. So they might be like strongly recommending or, saying, I I want you to start with a week or a month inpatient, but there are really like very consistent reevaluations throughout that process to make sure that people's rights are maintained, but also to make sure that people are getting the care that they will be most successful in. And what we actually heard from the transition to home program is that while people may start with a 3-month stay that initially was considered a required or involuntary admission, that then once the 3 months are up, the patient is actually choosing to stay for another 3 months because this type of care is really, they're finally getting the care that they need after a long time of not. And after they are able to perhaps get the medication that they need or start to be stabilized with a behavioral health treatment, that then people are saying, no, I actually do want to stay for another 3 months before I'm transitioning back out into the community or back out into housing, because this is benefiting me and because staying here for longer would continue to benefit me. So there are like, there's different there it's really just like not a one size fits all model, and it's really like very much on a case by case basis of evaluating and addressing an individual patient's needs based on what their circumstances are.
I have a couple of other questions. First, I'd like to say that we are in the midst of about to get something called a welcome center. Reading, I couldn't tell if that's what a welcome center is. From what we understand, the welcome center is that somebody would get off the street, be brought in, and stay there a maximum of 30 days to be evaluated, and sometimes the word was pre-evaluated, to say, where do you go next? Do you go to supportive housing? Do you need something more than that? Is that part of your program? Do you understand what we're saying? This was an agency called SUS, Services for the Underserved.
I'm not familiar with that. I would be happy to read up on it, but it's not something that we addressed in this plan, and it's not. Maybe my colleagues are familiar with it, but I haven't actually heard of the concept of a welcome center before.
So are you, if somebody's on the street, you immediately bring them to one place or the other? This is meant to be an interim stage before they go to longer term or something like that. Okay, well, that is
do you know if
something
it's
happening in our community soon.
okay?
I think in December is when they're supposed to be.
Okay. Do you know if it's do you know if is this for anybody experiencing homeless, or is it for like a specific segment of the homeless population?
I mean, it's called a low barrier.
Is it a drop-in center?
It's not a
I think
drop-in. It's different because a drop-in center, I think, is much shorter. I mean, the way they described it, the welcome center is more, they stay there, they get some help along the way, but meanwhile, it's an analysis of what's their next step.
There's only there's only a couple of them in the city so far. They're apparently designed for stabilization. So somebody would stay there for up to 30-ish days, get stabilized, and then be moved on to a longer term treatment, rehab, etc. type of shelter that they would, hopefully succeed at.
Okay. Yeah, I think it sounds like this might be getting more into general homelessness policy and like addressing the homelessness crisis. So while there's definitely overlap between homelessness and the serious mental illness crisis, that addressing the homelessness crisis writ large is certainly something that we need to be doing and that we're thinking a lot about. But this policy doesn't address, every it really doesn't address the overwhelming need to connect homeless New Yorkers, really all homeless New Yorkers, with resources and also housing and shelter. We are thinking really most about those with serious mental illness in this plan specifically, but we are certainly open to having conversations about homelessness policy and how we can improve on that as well.
I assume most of these people do have an element of mental health. These are those that they call it low barrier, that really have been
Yeah.
on the street for a long time and so on. And it's hard to imagine.
Yeah.
You talk about outreach. We hear about the Lenox Hill and Goddard below us, particularly, that actually roam the street. I see them. I see somebody hovered over a homeless person and talking to them. Is that what you mean by outreach? Is that how you would recognize recognize those that need help?
So there's different, yeah, so there's different types of outreach teams. Our plan really addresses the intensive mobile treatment teams, which really have a whole team of different care providers. There are other service providers in New York City. You mentioned Goddard Riverside. There are also others that do more general homelessness outreach, and oftentimes those programs are focused on connecting somebody to who is experiencing street homelessness to shelter, to a bed, to a meal, to a shower, things like that. But those outreach teams can also identify somebody who might benefit from the intensive mobile treatment teams because they need access to care, because they haven't been getting their medications consistently refilled, things like that. So those teams, from what I understand, can also help get people on the waiting list for the intensive mobile treatment teams. But there is a very long wait list. I mentioned that there are thousands of people on this IMT team wait list. So oftentimes what these outreach teams are doing is really trying to connect people with the best resources that are available. But it might mean putting somebody on a wait list and not necessarily getting them to immediate behavioral health care. And that's where we're really saying, like, we need to expand access to those teams that can actually provide the behavioral health care that people need. Oftentimes the people doing the general outreach are social workers, so they might really know the services that people need and that are available. But what we're finding is that there just isn't enough availability of those services and care, and that we need to expand them. I would also say that the component of our plan that addresses funding for behavioral health providers, that would be the homelessness outreach teams that do that more general outreach would be, I think that they would be benefited from, like, the cost of living increases, because oftentimes they're operating with city funding or maybe state funding. So if we can continue to get investment in those providers, then we would hope that they would see lower vacancy rates for those types of staffing roles.
And it may be the Lenox Hill workers, as an example, that say this is a very mentally ill person and go on to a Randall's Island type of program. Am I right?
Mhm.
That could be the way it starts.
Yeah, that is
I had
one
so many
that
more
is one
questions
way.
that you had answered along the way that I didn't quite understand.
Okay.
Talked about peer-to-peer. I sort of got the feeling it was almost like a community center or something like that,
Mhm.
where people may talk. What is the peer-to-peer that you were talking about, and community type?
Yeah.
Did you mean the
Um,
family?
no, so those are, I think that you're talking about the psychosocial clubhouses
Yeah.
that I
Yes,
that I
yes.
mentioned. Yeah, those are run by nonprofit providers. Fountain House, as I mentioned, is the biggest one. Fountain House has a lot of information on their website about what their model of care is for these psychosocial clubhouses. So I would recommend checking that out because they're really like the model for this type of care. They are, I think, the oldest psychosocial clubhouse provider, definitely in the city, maybe in the country. They've been around for a very long time. Uh, but yeah, it's really a peer network of people who can help connect folks to different educational opportunities, employment opportunities, different like vocational opportunities, as well as mental health care. And it's the Fountain House model is very much peer run. Like they have things like cooking classes and like employment training, and those are actually run by the members who have been, part of the clubhouse for a long time.
Do they live there? Is this
No,
housing?
it's not housing. It's more of like a drop-in center. So they're open every day. It's a place where you can get a meal. But oftentimes the people um who are like a member of the clubhouse that they go to, they might be somebody who is like in the shelter system overnight, but then to have somewhere to go during the day and start to
So they would not be
get
the
sorry,
very,
what's that?
they wouldn't be the very mentally ill people, the psychotic people or so on, would they? They would,
Um, it
they-
it might be people with serious mental illness, but who are more like stable on medication, for example, and just need that peer support network to ensure that they can continue to be successful in their treatment for mental illness. So it's typically not people who have like serious, untreated, like unstable mental illness.
I never heard of that type of program, and it sounds like a very important one.
Yeah, it's one. Yeah, that's why part of our plan was to do the CUNY social work and psychology school rotation there, is because it is like such an it's a very like unknown resource that provides tremendous value to people who need it.
It sounds like it. As I mentioned, I'm on the community advisory board as Wilma is of Metropolitan Hospital. And one of the discussions, because that is in East Harlem, that they have a large number of drug rehab places and so on, that's causing a problem in the area because it seems to attract the drug dealers along the way. One person suggested having a roaming um, somebody roaming to the different areas to look for people to help them, maybe with if they're overdosing or the other medication like that, or calling an EMS person or so on. Is that a program that you talk about? I think that On Point has been a program which is a drop-in center for people using drugs to try to
Mhm.
use it safely. Um,
Yeah.
it sounds great. My only problem is you can use it there legally, but you can't buy it. And therefore it attracts the illegal drug dealers that are there
Mhm.
and really causing havoc in the area, is what is said in that area. Quite truthfully, I think CB8 would not want On Point in our district,
Mhm.
for that reason. Um,
We've heard about some of the concerns with
it's
expanding
terrible.
those. And
I see
yeah, and
videos
we and
of it.
we
It's
yeah
terrible.
we do hear from Community Board 11 about about what they're facing as well. The intensive mobile treatment teams that I mentioned, they don't they can also be treating people who have substance use disorder. So if somebody has co-occurring serious mental illness and substance use disorder. They can treat both. But you mentioned the idea of like roaming mobile teams. So that kind of fits under under that umbrella. But we really just simply don't have enough of them. And there are, from what we are hearing from the care providers, there are a lot of challenges with that work. So I think that most providers think that there needs to be kind of a mix of both the like brick and mortar place, actual clinics where people can go to get care, as well as the mobile outreach for people that can provide treatment to people where they are. But I think you've touched on a couple of things there that like we definitely need more of those mobile treatment teams. And we also need to think about how the mental health clinics or substance use disorder clinics are how they are placed, and really carefully considering that, so that they're placed where the need is, but not like so concentrated in a way that people are concerned about, like the proliferation of drug use in a community that you mentioned.
Or drug selling also, which
Yes. Yeah, absolutely.
that's the serious thing, is the drug selling, it seems to me.
Mhm.
I think those are basically my questions along the way. Again, I just want to say thank you, and thank you to Borough President Mark Levine for this major, I mean, it's just not a simple program. How much of it exists now? I couldn't quite tell. Does any part of this program, is it all hopeful in the future?
Uh, so a lot of the different pillars of the program are building on things that already exist now. The inpatient transition to home beds, that's something that already exists, but there's only about 50 of them right now in New York. The IMT teams is something that already exists. So these are mostly things where we're not saying like we want to reinvent the wheel and propose a totally new program that is like nobody has ever heard of it before. It doesn't currently exist in New York City. I think that the one exception to that is the giving EMS workers the ability to provide the buprenorphine to people with substance use disorder. That's one thing that we don't have in New York City now, but we do have it as close as Camden, New Jersey has a program for that. So we're not proposing things that don't exist anywhere, and for the most parts it's things that actually already exist in New York City, but we're saying that there has been serious disinvestment in these different programs that do exist, and we really need to expand and make them bigger than what they currently are.
And what is your hope, or it all costs money?
Yeah,
So
that is really
if there's a certain amount of funds, what are you taking away from? What is your hope that these programs will in fact come to
yeah,
fruition?
so we are hopeful. The governor did include in her preliminary state budget both expanding the transition to home beds, as well as funding for the mobile treatment teams. In that, she didn't really say exactly like where across the state the beds would be located or where the teams would be. So we're hopeful that we would be able to, if it is approved in the state budget, that we would be able to get some of that funding dedicated to New York City. But I think we are clear that we are asking, this is like a very, very large funding ask that we're asking for across all of these different pieces. So we certainly understand that this is something that's going to take time, and we are going to have to continue to advocate for. And we do hope also that our community partners, such as community boards like yourself, will also be vocal supporters of this so that we can continue to put the pressure on our state and city partners to be spending the money where it's needed.
Well, I was going to ask you a question, but nobody else has a hand up so far. Am I right? Will, I don't see any.
No hands up.
Okay. There's no, is there something community boards have resolutions to say we're supporting. Is there something that you would want us to vote on and to discuss? Is there a resolution that would be helpful? I mean, I don't know, Will, if you have any ideas about it, or Jesse?
Yeah, I mean, I think that that's up to you to think about what are the needs in Community District 8 right now, and where can you be, like what parts of the plan are you seeing that are the most relevant to Community District 8 that you would like to see like really emphasized. You know, I think it would be up to you what form a resolution might take. Obviously, I'm not gonna, tell you what that would need to look like. But if the community board was interested in gesturing your support in some way, either through like a letter or a resolution, that's something that we, as the borough president's office, would be really thrilled to see.
Have you presented to other community boards? Whether it's
I
you or somebody else from the borough president's office?
I personally have not gone to other community boards. I think that my office has gone to maybe one or two other community boards, but we're really going to community boards that are reaching out to us and saying, this is something we want to learn more about. So we're, as you had done after the but it is something that we're hearing interest about, and I think that we will have requests to go to more boards as well.
It is a very major change to a very something that's affecting negatively our city and needs to be changed. Wilma, Lori, anybody else have any comment about it? Wilma?
I think a lot of information was given, and I'm excited to know about different things for future. Hopefully, for some of them to start soon. This is really needed. But
I think Lori and
I'm
Ellen
glad
from
that
the community board, are on. Is there anybody else from the community board on? I don't know.
No.
If they have any comment. Well, why don't we leave it from here? We may want to ask you, Jesse, to come back and maybe talk about specific parts to it at some point.
Sure.
I want to
Thank you
thank
very
you so
much.
much. I found this extremely interesting, important, and hopefully will come to fruition and have a major impact on our way of life.
Yeah, I'm certainly happy to continue the conversation and keep me updated on what you're thinking. Ellen, it looked like maybe you had another question. You're muted right now. I think they have to let you unmute yourself.
Yeah, go ahead, Ellen.
Okay, so I've been thinking about this, since you've talked about it, how are you advertising your programs to, like this program to find people in the community willing to take somebody in? And how are you funding that? So here I'm thinking that somebody who is mentally ill or street homeless would not have the funds to pay rent. So how are you then going to be matching somebody and then paying for this? Is there a pool of money? How do people willing to take maybe under market rent for a room? Is there, and how do you get those people? How do you advertise for those people so to find them?
Yeah, I think I might have mentioned that this really is a state program. So we are really thinking about having it's the state office of mental health family care. It's the family care program. So we really want to have the state uh, really put more money and resources in expanding the pool of providers who are interested in having people come into their homes. I just checked in right now in Manhattan, there's about 23 homes that serve about 100 individuals. So it's really a very small program right now, but this is something that the state needs to invest more funding in um, to reach more individuals in need. But it's all a state funded, state run program right now to connect these folks.
So what I'm imagining, instead of like a roommate program, it's more like a boarding house? Did somebody,
No, it is more like a roommate program. It is somebody who is, in somebody's home. It's not like a hotel or boarding house kind of situation. It really is somebody who is really kind of doing the um amazing act of opening their home to somebody in need.
well, did you just said 100 people in 23 houses?
Yeah, so
Or people?
a lot of people have more than one. I think most of the people in the program have more than one room that they're able to open to individuals in need.
And then
It's
people
really
getting
like a case. It's really a case by case basis. I think that everyone's home looks a little bit different, and how they have, everyone who is involved in this program, the circumstances vary widely. But that is really like kind of a core tenet of it, is that it's somebody who is opening their primary residence, but who has extra space to help somebody in need.
So it's more like upstate New York
Right.
or we're not talking about an apartment in New
A one
York
bedroom
where we
apartment in
only have
Manhattan.
No, it's no, there are other people outside of the city who are involved in this as
I
well.
see.
We
Okay.
there are It is something that's happening in New York City, but it's something that's happening across the state, and I'm sure you can imagine that somebody's circumstance of maybe being able to like open up their home to somebody might look very different in like Syracuse, for example, than it does in Manhattan.
I see.
Right.
So you'd have somebody, now I'm thinking of like we used to send people when I worked in an emergency room over to camp camp somebody or other. It was a Salvation Army camp. Then, where they would go for a month or two, to get out of the city. So now you're sending people from the city upstate New York?
No, people aren't being relocated necessarily. I can send some more information about this program. Well, maybe I'll send it to you, and then you can get it out, just so you can read a little bit more about it, because it is like, for being a fairly small program, there are a lot of details, and it is kind of a complex program. So maybe that can be,
And
if you have follow-up questions after I send you some resources,
and
feel free to let me know.
how are people getting paid how are these houses getting paid? Is it kind of like foster care, or is it more like?
Yeah, it's a similar kind of funding mechanism to that. Like, people are getting a stipend to
Oh,
or funding to provide this type of housing.
I do have one more question. You talked about the floor area ratio being increased if they have affordable housing, which we have now, and affordable housing isn't always very affordable because the AMI is always high. But you also said that possibly they would use it for supportive housing. Is there any way of saying you must use it for supportive housing? I can't imagine that they would want to choose it for supportive housing because that
Um,
effect on the other
yeah,
tenants of the building.
yeah. We're still awaiting the exact details of the City of Yes for Housing Opportunity, which includes this component of City of Yes would be the universal affordability preference. So DCP, I'm sure you might have heard that we expect sometime this spring for DCP to get us the full details of what the income breakdown looks like, etc. But one of the incentives for providing a supportive housing versus just affordable housing is that those would be city funded units versus like if it's just affordable housing units, the property owner is going to need to find a way to get that income mix to work out versus like for a supportive housing unit, they might be getting up to $25,000 a year in city or state funding to actually make this unit available for somebody as a supportive housing unit. So those incentives kind of do exist to a certain extent. We would love to see the city create additional incentives, but we haven't explored like a mandate for supportive housing. The Department of City Planning will also be coming out with what the income mixes will be that will be required for that additional 20% bonus. But we are expecting that it is going to be at deeper affordability levels than what is currently required for the bonuses right now that exist.
Thank you.
Sure.
So, any more questions, Will? Do you see? I think we've had it.
No, no more hands.
Great. Thank you so much. We really appreciate it and look forward to more dialogue and look forward to some success with the program. So please tell the borough that we feel that way.
I will relay the message. Thank you all so much for having me here tonight. It was great speaking with you.
Thank you.
Okay. Hope you all have a good rest of your night.
Thank you.
Move to, I would like to talk about, I don't know if it's old or new business for 1 second. One of the things we're going to be asked to do, and let's not do it tonight, but another time, is for the district needs statement for the budget. We were told we needed, I forget, Will, in June, by May or June, we would need it. Possibly this is something we could think about, is something we would want to ask for, that money to, for some of these programs.
Mm-hmm. Yeah.
I think that a suggestion about using a request is just some money aside, but sometimes we have to rent a room for one of our meetings. Or do we get all the rooms free and not expect to pay it all ever?
I'm not sure what you mean. For the meetings?
Like when for the meetings. Can they set aside money in case we have to pay to rent one of the room or space because we can't get a space for 1 month
Well,
or
I think
another.
meetings aren't, am I right, Will, that meetings going to remain on Zoom, so it's just the 1 or 2 meetings a month.
Not correct.
Meetings like this will not be off Zoom. Am I right, Will?
Yeah, that's, I mean, the current plan.
Yeah. So, okay.
I'm talking about meeting spaces for when we have our big meetings.
Our
Yeah.
full board meetings.
Sometimes, we have a hard time finding a space.
Yeah.
Maybe some money could be set aside in the budget or whatever the money, for that.
No,
Emergency
that's not this
room.
committee, though. Right. I don't know, Will, if you have an opinion about that. But let's do it.
Yeah.
Yeah, okay, Will.
That's a conversation for a different committee and a different time.
Right.
Yeah.
This one would be for programs such as this.
Yeah.
Okay, anybody
Yeah.
going to adjourn?
Go ahead.
Wilma, I want to adjourn, and Wilma's going to second.
Of
Thank
course,
you.
I love it.
Thank you, Will, as always, and Rose, thank you. This was our first meeting with you, and thank you for your help. I've talked to you a lot.
Yeah, Rose is great. All right, well, good night, everyone.
Good night.
Good night.